Let's see. All right, these are my disclosures. So we've talked about infrarenal, juxtarenal, and thoracoabdominal aneurysms, and this is kind of a summary where the technology is going for the management, endovascular management of arch aneurysms. Currently in 2018, what options do we have for the management of some of these more complex patients that we do not have the ability to use standard thoracic devices that are currently available? In general, many of these patients, if they're considered to be good risk, they undergo a total arch repair. This is a technically demanding procedure with complex circulatory management, hypothermic circulatory arrest, and in many of the series that are published, the morbidity and mortality is significant, especially on the high-risk patients or those that require reoperations in that region of the body. So why endovascular techniques for this area and these patients? These patients are increasingly complex. Many of them are surviving initially ascending aortic repairs and other aortic repairs, and in addition, they're getting older and have multiple additional comorbidities. So we have to consider other options for the management of these patients. What technology is currently available? And at least in the rest of the world, many of these devices are available in the hands of experienced operators. In the US, currently, all these devices have been used, but in a limited fashion. The Cook double branch device has been used in the US only in specific IDEs in the hands of a few individuals. And there's very little data published currently with this device. It's not in trials in the US. Probably the largest experience in a single center is from Stefan Haulong, who was mentioned just before. And he's had pretty good results, especially on the later experience after they've learned what are the issues with the initial devices. The Mona Lisa device from Medtronic and the Gore single branch device are currently in trials in the US. The Gore device is currently on its pivotal phase in the United States, and they're really enrolling the last few patients for the single branch portion into the subclavian artery, with a number of patients enrolled with reconstructions further into the arch. The early results seem to be very encouraging, and hopefully we will have one of these devices available in our hands, hopefully in the next year to year and a half. I'm going to concentrate many of my remarks regarding the Bolton, now Terumo double branch device, which we've had the earliest experience in the United States. They have some experience around the world, which I also will mention. So the Bolton Relay branch technology is based on the Relay NBS Plus platform that they've developed over the last few years. It's an off-the-shelf concept that has various proximal diameters, a standard branch position, and endograft length to accommodate the vast majority of patients with aortic arch pathology. Has a large window, which is approximately 5 centimeters in length, for ease of cannulation of the two internal tunnels, which are mainly used for the innominate and for the left common carotid artery. And it's intended for its deployment every time in zone 0, in the ascending aorta, native aorta, or within a graft at that location. It also has a patented proximal capture technology and the additional advantages of the Bolton Relay devices. So currently in the United States, there's an early feasibility trial which was started January of this year, and it's a prospective multi-center, non-blinded, non-randomized early feasibility study in 3 sites in the United States. A 4th site is getting ready to be added. And currently 3 patients have been treated. The 4th patient is scheduled for this coming Friday, with a target of 10 patients in the initial study. And those are the sites listed below. Basically, the technique to be able to implant this device includes the creation of a carotid subclavian bypass as the first step, and subsequent steps are made in an endovascular fashion. Access is obtained from one of the femoral arteries. The other femoral arteries also access in the venous system to be able to have pacemaker access for the deployment of the main device. And then access is also obtained in the right common carotid artery for retrograde deployment of that branch. After deployment of the main device, which is oriented in the arch appropriately under rapid pacing, that portion is deployed, and then the 2 branches are subsequently deployed, one from the right common carotid and one from the left common carotid artery, to be able to complete the reconstruction. So these are the first two patients that were treated with this device. Patient number 1 had an enlarging aortic arch aneurysm, and he was considered a poor candidate for surgical repair. He was 57 with a greater than 6 centimeter aneurysm, and his past medical and surgical history was extensive, with extensive coronary disease as well as aortic disease. He had had an EVAR and a FEVAR revision of his original EVAR. He had normal renal function, fortunately, and good perfusion distally and normal carotid vessels that could be accessed for this procedure. He underwent the left carotid subclavian bypass, as I mentioned before, and open exposure of the left common femoral artery and right common carotid artery for access for the other branches. Right femoral venous access was obtained for the temporary transvenous pacing. In this patient, due to his complex previous anatomy and complex aortic reconstructions, a 26 French sheath had to be placed to put the device through, as the aortoiliac segment needed to be straightened for the arch device to be able to be advanced and successfully positioned and deployed, as shown here. The device has multiple markers that are very easy to visualize, where you can see its proximal end, its distal end, the tunnels that will accommodate the two branches, and the window which is used to cannulate those two tunnels. After placement of the main device in a retrograde fashion, the patient underwent the brachiocephalic branch placement from the right carotid and a left carotid branch placement from the left common carotid artery next to the carotid subclavian bypass, which had been performed before. To avoid a retrograde endoleak in this particular patient, retrograde access was obtained of the subclavian artery, and an Amplatzer plug was placed to avoid retrograde flow into the aneurysm from the subclavian artery. Here are the images after the completion of the procedure. And this patient is now a few months out, and his first CT scan shows successful exclusion of his aneurysm, and all the branches are patent. Patient number 2 had an aortic arch enlarging penetrating ulcer that had turned into a bit of a pseudoaneurysm in the mid-arch. She was 71, and her main problem was she had severe obstructive pulmonary disease. Additionally, she had aortic disease with a right common iliac artery occlusion and severe spinal problems. She had normal creatinine and good perfusion distally, and this patient underwent the same series of steps, the same procedure as described before for the other patient, with deployment in the ascending aorta and into the proximal descending thoracic aorta. Completion angiogram suggested that everything was reconstructed appropriately without any issues, and this patient is also a few months out at this point, and her first follow-up CT scan showed that the aneurysm was completely excluded and all the branches were patent. In these two patients, we learned a few things about the device. This is the length of stay and ICU stay on both of the patients. The first patient, his only complication, he was diagnosed as having a small retinal artery occlusion, which may have been a small embolus to that area. It only involved 5 to 10% of his visual field, and he's completely recovered at this point. The second patient was in the ICU for a prolonged period of time due to her pulmonary disease, which was clearly severe, and it took a while to be able to get her out of the ICU. She developed lower extremity weakness, and there was a significant concern for spinal ischemia. She had a spinal drain placed at that point, and ultimately MRI showed that she had no signs of spinal ischemia, and her problems, which fully recovered, were more associated with her osteoarthritis of the spine. And ultimately she was discharged and has recovered reasonably well for an elderly patient with multiple medical comorbidities. The worldwide experience with this device is mainly of the double branch device. The company started its evaluation with a single branch device. They had 5 patients for an initial feasibility experience in a few centers in Europe, and then they moved rapidly to a double branch device as there was a much more interest in this device. As of June 1st of this year, 133 patients have been treated worldwide, with 3 patients of those 133 being the ones treated in the United States through this custom-made program outside of the US. So in conclusion, the initial experience with the Bolton relay branch device, now part of the Terumo family, in the US feasibility trial has been very encouraging to date, and we're looking forward to using the device and learning more about the management of these complex group of patients. Thank you very much.